new faces that we don't usually have on this meeting, and you're all very welcome. I am very excited about today's meeting because we've managed to get ourselves a wonderful guest. But just first, as a way of introduction, the Gastroenterology Echo is hosted locally by the Gastro Foundation in collaboration with Project Echo of the University of New Mexico. We've got weekly sessions like this, and we rotate between several subdisciplines in gastroenterology, and every seventh week or so, it's a turn of pediatrics. So our chat is always open for questions, or you can raise your hand at the end of it. And that's about all the household rules that I want to tell you about. But I do want to just briefly introduce Professor Venter, who is speaking to us all the way from Colorado today. And I think those of us who are in the allergy field or in the gastroenterology field have definitely read many of Carina's papers over the years. She studied in the Free State, and as a dietitian, she then moved on to the UK, where she, I think, rose to fame and wrote all sorts of guidelines, too many to mention. She wrote chapters in books. She's really the expert on food protein allergies, I would say. So it's exciting to have you here today, Carina, and especially talking about a topic that I think is still foxing or outfoxing many of us. I think we're missing kids with FPARs, especially chronic FPARs. And when we do pick them up, we struggle to really manage them, especially from a dietary point of view. So this is such an exciting talk. And thank you so much for agreeing to give it to us. Over to you.
Right. Thank you very much for the invitation. I'm very excited to be here. I also just had a text from my boss, David Fleischer, to apologize for not being able to join us today, but he's literally in clinic. And so today we will be discussing food protein-induced enterocolitis syndrome. And I'm just going to share my screen with you. Give me 1 minute. Share the screen. And okay. Do you see my screen? And then I'm going to do the presentation mode. Okay, everything in place?
Yes, it is.
Okay, good. So, so as you've heard, I'm South African, as you can also probably tell from my accent. I grew up in Bloemfontein, and so I studied at the University of the Free State before I went to the UK and now to the United States. And I just need you to be aware of my disclosures. I do consulting for a number of different companies, but nothing relevant to what I'm going to do today. So I very much, we just talked about the NIH, and one thing I struggle with in the United States in terms of doing research is they always want to have an hypothesis. And I say, I don't have any hypothesis. I have lots of questions in my head. And so I do my research to answer my questions. And I also like when I teach to actually look at the questions I have. And these are the questions that I often get asked by allergists. I also teach the gastroenterology fellows every year. That's the questions I get, and also the questions I get from parents. And so I'll start the presentation with a little bit of overview of food allergy presentations, bit of immunology, not too in detail, and then I'll really get to the 10 questions. Should I avoid FPIES trigger foods while breastfeeding? Which are the most common foods associated with FPIES? My child's FPIES is triggered by rice. Should I avoid all grains? I cannot tell you how many parents, doctors, and fellows has asked me this question. Does all children with FPIES react to multiple foods? I don't know whether your patients go on social media as they go on my patients, but they come and see me and they have a whole shopping list of foods that they've read up about that causes FPIES, and they think this kid is reacting to anything and everything. Which order should I be introducing food? You know, Shall I start with apples? You know, where does peanut go into all of this? Should I be concerned about nutritional deficiencies in children with FPIES? When can I start using plant-based milks? This is a big question because of the cost of infant formula. So we try to transition children as soon as we can onto plant-based milks, and I'll give you very clear guidance about that as well. A paper I've just recently written for the World Allergy Organization, cow's milk allergy guidelines, so the DRACMA guidelines. Should I be concerned about feeding dysfunction in children with FPIES? Am I just going to wean or introduce solids into this baby and this baby is happily going to eat? Unlikely in FPIES. We'll talk about that. And then what about this whole concept of baked foods? I don't know whether you've heard about milk ladders and egg ladders and these baked muffin challenges, but that we know they have a role in IgE food allergies, but where does this all fit into FPIES? And so if we just go on to the next one. So, you know, what is the difference between FPIES and EOE in particular, I often get. So, you know, food allergies are really a big umbrella term for the IgE-mediated food allergies, which everybody actually define as food allergy. But that is really, for some extent, particularly in the first 3 years of life, the minority of the food allergies we see. And so IgE-mediated food allergies is typical when a child would eat something containing peanut, or they may have an IgE-mediated reaction to milk the first time infant formula is introduced. Reactions we normally say occur within 2 hours. My practical experience from having done thousands of food challenges is if that child's going to react, 80 to 90% of cases, you will see the reaction within the first 5 minutes. But, you know, sometimes we do get more delayed symptoms. And then we have this big term of non-IgE mediated food allergies. And that is FPIES, or food protein-induced enterocolitis, which I will get into all the different presentations on the subsequent slides. We have eosinophilic esophagitis. That is where we have narrowing of the esophagus over time. It's very, very different from FPIES because EOE, we never see immediate symptoms. They may have some reflux, but they don't have the projectile vomiting as we see with FPIES. These kids may grow Felter as well, and they often have atopic dermatitis. But it is really the symptoms and the abdominal pain and the food refusal that occur over time, and the symptoms primarily because of what we see that's happening in the esophagus with infiltration of eosinophils. We have food protein-induced now, proctocolitis, food protein allergen-induced proctocolitis. I think you all see that. We see this primarily in breastfed babies where they have blood in the stool. But these children, they don't grow Felter, or they don't have failure to thrive, as it's called in some countries. They grow well, they're happy, but they have blood in the stool. I'm not talking about that today, but, you know, in America, there's huge debates, and I even see that amongst the allergists I work with, where some may take milk out of mom's diet to stop the blood in the stool, and others may say it's a benign presentation of food allergy. Mother can continue to consume milk, and over time, you know, the child will outgrow it and the blood will disappear. The majority of the parents I see don't like the blood in the stool, and moms rather take milk out of their diet. Then we have the mild to moderate non-IgE mediated food allergy. And this is the bit where I'm going to highlight the chronic FPIES later on, because I think there's some confusion about the two terms, and I will explain the differences later on. So I hope I clarified EOE and proctocolitis. We're going to come back to FPIES and mild to moderate non-IgE mediated food allergies.
I gave you the number to go.
Okay. Then in terms of the mechanisms of non-IgE mediated food allergies, you know, people always want to know, so what is the underlying immune system, you know? And I can tell you that initially when I moved to the Isle of Wight now about 2001, which is now about 23 years ago, and they asked me to work in the food allergy clinic, I said, absolutely not. I am a dietitian who likes to work in gastro. I like to work in the intensive care unit, and with my background from South Africa, you know, I loved working with burns and malnutrition. And I said, I'm not doing food allergy. Just forget about it. But neither they didn't have anybody else, so I had to go do the clinic. And at the end of the clinic, I said to the doctor, "I am not coming back. Just know that, because I'm trained with diseases with clear classifications. We understand what's wrong with the patients. They have a diagnosis, and we can work out their nutritional needs. But in food allergy, everything seems to be a little bit unclear." I went and I did my PhD in immunology in Southampton, allergy and immunology, to understand what's going on in these food allergy presentations, because I had to continue doing the clinics. And I absolutely fell in love with allergy, and I've done nothing else now for about 23 years. But one of the things that I will tell you about food allergy, and that goes across all the presentations, is we still have so many questions about the immune system underlying it. And so initially with FBIS, we said it's simple. It's a neutrophil-driven disease. The children, there's a lot of Th1 cytokines flying about, and it's very different from IgE-mediated food allergy and EoE, where we see more a Th2 dominant profile. In EoE, particularly driven by IL-5, some involvement of IL-13, IgE-mediated diseases driven by IL-4 and IL-13. So they separate, and then we have FBIS very separate again, neutrophil driven, and it's all very, very simple. Proctocolitis, can be eosinophil driven or can be Th1 driven, but it just depends, I think, at what stage of the presentation you look at these kids. And then, we started to see that these kids with FBIS actually have positive skin prick tests to the foods, not causing IgE type symptoms, but actually FBIS type symptoms. And so we thought, okay, perhaps it's not that simple, that FBIS is a complete entity sitting by itself, just Th1 driven disease. And then, we have this wonderful data from Cecilia Barin's group. She used to be at Mount Sinai. She's now at the University of Chicago. And this slide may be difficult for you to read, but I think the only thing that we need to understand and take from this slide is that when we look at FBIS, we can still see the involvement of the monocytes, but lately we've also been seeing more involvement of IgE-mediated disease and even some Th2 cytokines. And this is now why we also have the term atypical FBIS, which I'll explain to you on a later slide. But I just wanted to give the background. There may be some children with a simple Th1-driven disease, but there's also some children we see where there definitely is some combination of Th1 and Th2 mediated reactions. So, but what is the natural history and risk factors before we get to FBIS? So, classification. So, food protein-induced enterocolitis. This is a study done in the United States. The prevalence is really low. It's considered to be a 0.35%. Most children outgrow the trigger foods. But what was fascinating was we know that FBIS occur, particularly FBIS in adults, occur mainly to seafoods. And so that was no surprise. We were not surprised about the prevalence of FBIS we saw in the children from 1 year to about 3 to 5 years. But the fascinating thing was that there are some FBIS that seem to be lingering in children even up to the age of 17 years. And we're not clear how many of these adults actually still had childhood FBIS. Although looking at the paper, the majority that, reported FBIS to fish. But so it seems that in a small minority, children may actually continue to suffer from FBIS, and not everybody outgrows it by 5 years of age, as we previously used to think. So this is another guideline I've been involved with, and we're currently rewriting it, the International Consensus Guidelines for FBIS. And you can see that we had many different specialities across many different countries of working on this guideline. So, acute FBIS, there's 3 types of FBIS. We're going to talk about acute, chronic, and then atypical FBIS. So acute FBIS is the one that we mostly know about. The child eats the food, or the adult. Vomiting occur within 1 to 4 hours. We always used to say within 2 to 4 hours, but the guideline panel felt strongly it could be 1 to 4 hours. They become lethargic, pallor, and limpless. So they just literally, it looks like a tap has been opened. These kids just vomit and they keep vomiting and they keep vomiting. 20% go into shock, 15% with methemoglobinemia. Some may appear experience diarrhea, and the diarrhea can contain blood. Many don't. So often people would say the child doesn't have GI symptoms. They didn't have any diarrhea. Well, actually vomiting is a GI symptom, but they only vomited and they didn't have diarrhea. Therefore, they don't have FPIES. But it's important to remember that some children may not have the FPIES, and if we do a full blood count, there's often an increase in neutrophil count, which will peak 6 hours after food ingestion. But once you take the food out, you won't get an increase in neutrophil. So it's really just over the period of being symptomatic. We normally, when we do challenges to these children, we put IVs in, and then we normally treat the nausea or the vomiting with ondansetron. So chronic FPIES, this is where we get confusion between chronic FPIES and children with mild to moderate non-IgE mediated cow's milk allergy, because the initial symptoms look very similar. So these are young infants. They may be fed milk or soy formulas, or mom may have these foods in their diet. They have watery diarrhea. There could be mucus or blood in the stools, which would also then confuse the picture with proctocolitis. They may have some emesis, but quite often we're not really clear whether these babies are just refluxing, like in non-IgE mediated cow's milk allergy, or in GERD, or just reflux disease, or whether they actually have vomiting relating to FPIES. They may have low albumin and total protein. That's not always the case. They may have elevated blood cell counts with elevated neutrophils. So if you get the low albumin and the low total protein and the neutrophils in this child with chronic symptoms, where there's some diarrhea, plus or minus mucus, plus or minus blood, with some reflux, which could be, vomiting, and you have the blood profile going alongside that, plus growth filtering, you know that you're dealing with chronic FPIES. If you do not have changes in the blood profiles, the only thing you can do to know that it's chronic FPIES and not just a type of GERD or mild to moderate non-IgE mediated cow's milk allergy is that you need to bring them into hospital. You have to give them a food challenge with sufficient amount of cow's milk or soy, whichever the food you think is a problem, and they will then go into acute FPIES. If you actually done the food challenge and the child has no acute symptoms of FPIES, then you know that you're dealing with chronic FPIES. Now, this is easy for me to say, because who's going to bring a baby with some diarrhea, some vomiting, plus minus reflux, with a very normal blood profile and some growth filtering into hospital for a challenge to see if we can induce acute type FPIES? Probably nobody. And so I think, in many ways, we are dealing with chronic FPIES as mild to moderate non-IgE mediated cow's milk allergy, or vice versa. The only time when it becomes an issue is, when you're going to reintroduce the food at home and they may have symptoms of acute FPIES. It's very hard to tell you which child will have those acute symptoms at home and which will have no acute symptoms at home, but we normally take growth filtering there as our red flag. In children with growth filtering, we think we may be more likely dealing with chronic FPIES, and children where there's no growth filtering, we think we may be dealing with really mild to moderate non-IgE mediated cow's milk allergy, and that may also sway our decision about, are we going to introduce the food in hospital, or are we going to introduce the food at home? And then the atypical FPIES, these children have acute FPIES, very clear acute FPIES, but if you skin prick test them, they may have a positive skin prick test or specific IgE in the blood to cow's milk and egg. And these children do not outgrow their FPIES very early on. we've seen children with FBIs 6, 7 years of age, and they can often go from FBIs, where they have very clear FBIs, to cow's milk as a child. They're sensitized. And then when we actually do the reintroduction challenge to see if they've outgrown their FBIs, they have immediate type symptoms like hives and, immediate onset vomiting within the first 5 minutes of doing the challenge. They may have rashes, and they may even have anaphylaxis. So just be aware of these children with the atypical FBIs, that when you do challenge them, you may actually get symptoms much quicker than expected, and it may be typical of IgE-mediated disease. So now let's get to the practicalities. I've now given you all the background, and I'm keeping an eye on the clock. I'm going to try not to overrun. But this is now when I'm really in my skin, when I get to the practicalities and I can sit there and talk to the families. And so mom saying, should I avoid the FBIs trigger food while breastfeeding? The simple answer is probably not, because we actually only have 2 good studies and 1 case study, which I've highlighted in red, which shows that less than 5% of children with FBIs will present with FBIs while exclusively breastfed. So the only time that we would consider taking milk out of the breastfeeding mom's diet is if she was breastfeeding exclusively and the kid had FBIs. If she was breastfeeding, introduced yogurt or introduced a pea milk or introduced soy, and the child then started to have FBI symptoms, we would say, leave your diet alone, continue to have the allergen in your own diet because the child was not symptomatic. We're only going to change the child's diet. So in most cases, mothers don't have to change their diet, which is helpful, because I tell you, when do I get to see kids with FBIs? They're 9 months old. They have a few foods in their diet, perhaps 2 fruits, 1 vegetable. Mom tried baby rice, which they do in America. No kids should eat baby rice. They had FBI symptoms. Then she might have tried some oat. Again, FBI symptoms. Mom decided this kid is allergic to everything. And so at 9 months of age, mom is breastfeeding. There's 2 fruit and veg in the diet. Baby is growth faltering. Mom is exhausted. Mom has lost a lot of weight. And so the last thing you now want to say is take more things out of your diet. You want to say, keep your diet as is. We're going to deal with the baby's diet, and then we are going to get you both better. So which foods are most commonly associated with FBIs? And I did look to see if I have any studies from Africa, because I do think these foods may look different. Milk is a common FBIs trigger across the world. Doesn't matter where the study was done. We see a lot of soy FBIs in the States, but no soy FBIs in Israel and Australia. Oat and rice FBIs we see in most countries, but more so in America than other countries. And then these cases of FBIs, wheat, corn, peas, banana, avocado, sweet potato. Look, I've written a paper on that, and I'm literally telling you that 5 kids might have had FBIs to sweet potato ever. And numbers of avocado is now increasing, so perhaps we have a little bit more than 2 handsful. Same with banana, less than 10 cases we are aware of ever reported. So even though I put them on the slide, it doesn't mean thousands of kids with FBIs are going to have banana FBIs. So these really are the minority of foods. Oat and rice go together, milk and soy go together, egg is sort of like somewhere in the middle, but these are the main triggers. And I'll go through that again on another slide. So here you can see this is a study from Sue et al. It's looking at 4 hospitals in the Boston area. And you can see here in America, main triggers, oat, rice, milk, and egg. Spanish studies show that they see predominantly fish or seafood-driven FBIs. So like I said, we might have had corn in here in Africa, where I've never seen a child with corn FBIs in my life. But if you've seen a kid, you want to put it in the comment box, then we can discuss that later on. So I don't have voting system. And you don't have to say anything. And at the moment, I can't see the comment box, but I just want you to think for a second rather than just listening to me. This is, like I said, the most commonly asked question I've ever had relating to FBIs. The child or my child's FBIs is triggered by rice. Should I avoid all grains. And the biggest issue here is wheat, because if we can put wheat back into a child's diet from a nutritional point of view, we just open up the diet so much. So should we be concerned about wheat FBIs in a child with rice FBIs? I don't know if somebody do you think there's a 5% chance that they may have wheat FBIs less than 5, 15, 50%? What do you think is the chances of wheat FBIs in rice? If child have rice FBIs?
I don't see any responses, Carina. I think
Okay.
everyone's scared.
Okay, that's okay. I tell you what, if I didn't read these papers and if I did not get asked this question that much, I wouldn't know the answer. But I do know the answer because I have gone to look it up. About 5% of children with rice FBIs will have wheat FBIs. But you can see, the chances of being, well, the 5% is really the bottom two lines that I'm showing you. So 5% of children with rice FBIs will have wheat FBIs. Much higher risk of having oat FBIs when you have rice FBIs, and almost no chance for corn. But myrrh is based in Australia, so I'm not surprised that they don't see corn FBIs. And like I said, perhaps we need to look in Africa in particular at corn. But so we now actually, get you a clear answer, if you have a child with rice and oat FBIs, we will actually introduce wheat at home without delay. And we've never had the reaction so far because it helps in these children that's already malnourished with a lot of feeding dysfunction to get the diet normalized a little bit better. So this is the table from the iFBIs guidelines. So you can see if a child has FBIs to cow's milk, it's about 40% chance of having FBIs to soy, but less chance of having FBIs to solid foods like, for example, grains or legumes or poultry. Soy, again, about 40% chance to have a cow's milk FBIs. So practically, let me give you an answer. If they have cow's milk or soy FBIs and we want to introduce the other food, we would normally either wait, which we probably shouldn't, or we would bring them into hospital and give them a challenge to that food because we know there's a high risk of co-reaction. If they have a solid food FBIs, like, for example, banana, they may have solid food FBIs, let's say to tomato or sweet potato. But again, we don't actually challenge them to these foods. If they have a banana FBIs, we would still normally do sweet potato or tomato or even oranges at home. Cow's milk with any other solid food, less than 25%. So if they have a legume FBIs like beans or lentils, then the 80% chance of a soy FBIs, we probably wouldn't even challenge. We would just say avoid soy. And if they have a grain FBIs, they have about a 50% chance of having allergy to another grain. But I would really say it goes for rice and oat mainly. It really doesn't include wheat and corn and quinoa. And then poultry, if they have a FBIs reaction to turkey or chicken, then they have about a 40% chance of reacting to another kind of poultry. So again, if they have chicken FBIs and they particularly want to eat turkey, we probably would bring them in for a challenge. It really is a clinical decision. It also really depends here on the family. Everything in allergy depends on the family. If I have a mom whose child has got a sweet potato FBIs, and she is breastfeeding and she needs to introduce a formula so she can get some sleep, continue breastfeeding as much as you can, but perhaps just help with a nighttime feed. Or I need to get some oatmeal into this child's diet or porridge. And I can see this mom is just not going to do this. There is no chance that she's going to feed this kid any food because they had a horrendous time with reactions with the sweet potato FBIs and in the emergency room or in the A&E, or if I can use my Afrikaans, we're just for now, ongevallen. Then we will bring them in and we will do a milk FBIs challenge, even though we know the kid won't react. And we will do an oatmeal FBIs challenge, and we perhaps may do a rice one until we get the mom to believe that this child is now probably going to be okay introducing these high-risk foods at home. Other families I see, mommy's as calm as anything. The child might have had an FBI's reaction to milk, but somehow the vomiting stopped without treatment. They did get to the hospital, but by that stage, the child was already stable. There was no IV fluids put in the child, no need for ondansetron. And then, you know, if I discuss the same pattern of introduction of foods with this mom, she's going to absolutely do it. She's going to go home and do it. And so you really have to work with the family and then, of course, with the facilities for doing oral food challenges as well. So I've already told you about these mothers that come in with this shopping list of foods. And so how many children with FBIs do you think have FBIs to more than one food? Less than 10%, 10 to 25%, 50%, 50 to 75%, or more than 80%? How many kids do you think have FBIs to a single food? Now, again, you don't have to vote. I just want you to think about it. Now, I can tell you that based on what the mothers tell me, I would have said more than 80% of children with FBIs have more than one food trigger, okay? But it is the complete opposite. About 50 to 80% of children with FBIs have FBIs only to a single food. And so really the vast majority will have one food. Milk and egg, milk and soy go together, and then we have the oat and the rice go together. But the other foods really tend to be mainly single foods. And this is, again, this data from the Boston team showing how they seem to coexist. They don't cross-react. Cross-react means they have two similar proteins and the immune system can't tell which one it is. For example, if you are allergic to birch pollen, there's the same allergens in birch pollen as there is in an apple. So when you eat an apple, your mouth is going to itch. You're not going to get anaphylaxis because your body doesn't know whether you're eating an apple or inhaling birch pollen, which is giving you allergic rhinitis. That's cross-reaction. When it comes to FBIs, there's no cross-reaction because there's no similar proteins to milk and soy, no similar proteins to rice and oat. So we don't know why they coexist, but they do. And so it's important to understand these patterns and why I have the information for you on this slide that I've already shown you. Then which formula is recommended for the management of FBIs? So if the baby is reacting to cow's milk and we need to give a replacement formula, there's this big debate about whether it should be an amino acid-based formula. I don't know exactly which ones you have in your country, but these are the most expensive formulas. It's easy to tell by the price tag, or whether we can give them an extensively hydrolyzed formula. And so we always used to say in FBIs, it always has to be an amino acid-based formula, which is a huge cost implication. But the updated DRACMA guidelines, which was published just like 2 weeks ago, I'm one of the co-authors, we've now said that really we can start with an extensively hydrolyzed formula, which should be fine for the majority of children. If there is severe growth faltering in a child, I normally go for an amino acid-based formula if the medical insurance will cover it, because they do seem to grow better on the amino acid-based formulas than the extensively hydrolyzed formulas. But if cost is an issue, it's best to just, for safety's sake, at least go for an extensively hydrolyzed formula. And I don't know if you have rice formulas in your country, hydrolyzed rice formulas, but the DRACMA guidelines said we don't know if we should be using it. In which order should foods be introduced? You know, so we start with the lower risk foods and we go to the higher risk foods. So I'm sure you've all heard about the fact that we should give peanuts early to babies. And now in the FBI's guidelines, I'll show you the table on the next slide, we said perhaps not peanut as a first food. And so the whole world's been writing to me saying, why do you say delay peanut introduction in people with FBIs to around 9 months? We don't have to, okay? So we do not need to wait with peanuts in children with FBIs till about 9 months. You can give it as one of the first weaning foods, but perhaps not, you know, the first food. And so I will put the next slide for you in context. So normally with FBIs, we start with broccoli, cauliflower, parsnip, turnip, pumpkin. We do blueberries, strawberries, plum, watermelon, peach, Lamb is the lowest risk food. We do quinoa. Millet is a low risk food. But in the States, at least, I consider corn to be a lower risk foods. And then we do the tree nuts. And then from there, we can move on to other vegetables like squashes, carrots, white potato, green bean. We can do apples, pear, and oranges. We can start with beef. We can try the other grains. But like I said, if I'm desperate to get wheat in the child's diet, we do a challenge and it goes into my first group. And then with peanuts, we just said, try some other tree nuts first, like perhaps cashew or almond before we give peanut, but there's no need to wait. And in Africa, where I know, everybody loves peanut, and I would do peanut as one of my very first foods. It's an amazing source of protein. It's got really good fats in. Most children, if we get peanut into their diet, eats it very early. And so in terms of peanut, I would definitely do it as one of my first foods and not wait with it. And then the higher risk foods, that could be sweet potato, green peas, banana, avocado, the rice cereals and oat cereals, and then also milk, soy, and poultry, eggs, and fish. So with these, we may wait a little bit and try and get the lower risk foods in. So, there's no spinach on this list. So I normally would do spinach as one of my first thing. When I grew up in South Africa, I don't know what the proper name is, but we grew up with marog. And so, that would be one of my first foods if I had access to that. In America, but we have spinach, and so I would do that. And so really look at your local foods, your local food traditions. I know growing up in South Africa, we call anything yellow a pumpkin, but you may have many different kinds of pumpkins and squashes. All these things are really low risk, and I would put them first in there. And so just, like I said, look at your local food and make sure that you modify this table according to local eating practices. Peanuts, we do see more peanut FBIs. Having said that, I would do it as a first food, and I still do that. We have to be mindful that because we're introducing peanut earlier for prevention of IgE-mediated type peanut, we are seeing more peanut FBIs. And this is actually a group reporting this data from their local clinic, where they saw 28 patients with peanut FBIs. We probably 10 years before, they would have had 28 patients in total with FBIs. Now they have 28 patients just with peanut FBIs. So be aware that it can be an issue, but I think the issue is still not big enough that we want to delay introduction of peanuts. Let's just get it in. This is just for you. I'm not going to go through it in too much detail. A slide we present, this paper is published in Annals of Allergy and Immunology. I published it with a group of dietitians. Often doctors say to me, yeah, I hear what you say. And the moms say, yeah, we hear you, but we want amounts. And so, if the child is not allergic to milk, we say 1/4 to 1/2 cup of dairy foods or plain yogurt. But if they have milk or soy FBIs, and you have access to coconut yogurt, then I often would use that. I used a lot of pea milk in the past in children with FBIs, but now we're beginning to see more pea FBIs as well. So I sort of try to use coconut-based, milks or almond-based milk or yogurt, which we do have access to in America, but I know perhaps not in all countries. Grains, we normally say 1/2 to 1 ounce a day. I'm now talking here about children 6 to 12 months old. In America, we have a huge issue with iron deficiency, so we normally recommend fortified grains. And I think if the child's still breastfed with no infant formula, which is fantastic, it's best to use iron fortified grain. And then milk and the meats about 3/4 to 3 ounces, and that can come from all these different forms. And vegetables about 1/8 of a cup to 1/2 a cup. So that's just really serving sizes for children. They may have 1 serving, they may have 2 servings. It's just to give you an idea of serving size, and the number of servings will really depend on the child. Some 6-month-old babies are really not ready to eat. They may have 1 or half a serving, and some 6 months olds are much better eaters, and by 12 months the children may have about 2 to 3 ounces servings of each of these serving sizes. You don't have to worry about may contain or produced in a factory or packed in the same area. May contain or trace amounts are not relevant in FBIES. We can completely ignore it. And safe ingredients for all children with FBIES, irrespective of the trigger food. They can have all kinds of refined grains. They can have distilled vinegar. They can have sodium bicarbonate, baking soda. They can have enzymes in food, spices, salts, sugars, preservatives, artificial flavorings, guar gum, xanthan gum, other gums, and then, also vitamins and minerals. So all of these things, the preservatives and the sugars and the artificial flavors and the gums and the xanthan gum, even though they're tolerated by children with FBIES, it is really not great for your gut microbiome and really not great for your epithelial barrier. So I normally say to FBIES families to just cook at home, keep it simple. We expand the foods one by one every week, perhaps 5 new foods every month. We try and get as much diversity into the diet as possible and really stay away from commercially available food or ultra-processed food because, it's just not beneficial for the gut. And so perhaps tolerated, but not great for the gut. Should we be concerned about nutritional deficiencies in children with FBIES? If you have access to a dietitian, I would most definitely refer every single child with FBIES to a dietitian because we see a lot of nutritional deficiencies in these children, calories, protein, fat, vitamins, and minerals. So they need a diet assessment, and they also may need bloods to particularly look at iron status. When can we start plant-based milk in children with FBIES? The DRACMA, or the World Allergy Organization guidelines, have always said up to 2 years of age. We've now dropped it down to about 1 year of age. I'm showing you this chart. These are American brands. But what I want to show you is that protein in plant-based milk can vary from 8 grams per cup to 0 grams per cup. The calories can differ from 160 calories per cup to about 50 calories per cup. Fat also differ, carbohydrates, fiber, calcium. You can see this one has about 460 milligrams of calcium per cup, and it can go down as low as 40 and 30. And same with vitamin D. So if you are going to put a child on a plant-based milk and you don't have a dietitian, you're going to have to just do your homework and go to your local shops, see what is available, and try and find the ones with the highest protein and the highest calorie contents, because the ones with no protein and no calories, like this coconut milk, is not really beneficial for a child. It may have a lot of calcium, but really protein and calorie-wise, it's not contributing to the diet. So this is the factors I'm going to ask you to think about it, but the answer is I'll tell you all of the above. We can go from a formula to a plant-based milk in a child that's at least 1 year of age. They eat a varied diet. So if they're still picky eaters and they have like 10 foods in their diet, even if they do, I wouldn't move them onto a plant-based milk. I want the child to be at least 1 year of age or older, plus eat a varied solid food diet. Gets at least 2/3 of the energy from the diet. If they have to overly rely on their calories coming from an infant formula, and you take that formula away, they're going to be deficient, because I showed you just now that not all plant-based milks are great. They need to eat all the textures, enough protein, fat, and micronutrients, should not have any feeding difficulties or micronutrient deficiencies or any additional restrictions because of religion or culture. So really, a child that's suitable to go from a formula onto a plant-based milk is a child that eats well, don't drink too much formula, hasn't got picky or picky eating or fatty eating or feeding difficulties. They don't have any nutrient deficiencies, and they eat all the textures they're supposed to eat. But if you're not sure about that and you have a dietitian, again, another reason to get the dietitian to see them. So this is a busy slide, and I'm not going to read them through all because it's a very easy slide to understand. They sent children with FBIs and IgE-mediated food allergies a questionnaire that diagnosed feeding dysfunction. And we know that feeding dysfunction is a problem in children with IgE-mediated food allergy. But absolutely fascinating. For every single question asked, feeding dysfunction was significantly a higher or a bigger issue in children with FBIs than children in IgE-mediated food allergy who already have feeding difficulties. So, we really need to make sure that when we see these children, I'm trying to go back, with FBIs, that they get a good feeding assessment and that they see a dietitian or a feeding expert. In America, we call them feeding therapists. In England, we call them speech and language therapists. So in some countries, they're called occupational therapists. So whichever healthcare professional, in some countries, it's the dietitians deals with it, get the referral, and the dietitian can be so helpful in working at the beginning phase of each. If they're expert, they can deal with all the fishing issues, but they will also be able to advise you as a clinician that it's time to get other experts into account. So can children with FBIs eat baked food? So this is a paper that was published last year in Jackie IP, and it actually showed that when they challenged children with FBIs to baked milk, this is all the children they challenged, the majority actually passed. They had 3 fails out of the about 11 they challenged. And so we are now much more inclined to actually bring these kids in, feed them a muffin if they have milk FBIs, because if I can get them to eat a muffin, they can have all kinds of muffins. We then do corn muffins, savory muffins. It doesn't always have to be sweet muffins, but they can also have cookies. So I can do homemade cookies. I sweeten it with apple and banana opposed to sugar. But it's really important textures to get into a child. It brings extra calories into a child. And if you have access to protein powders, and you can find a protein powder with a suitable allergen that the child is not reacting to, then you can actually fortify, the cookies and the muffins with protein powder. But again, a dietitian can help you with these recipes. So in summary, there are many nuances to the dietary management of FBIs. An individualized approach is required. Of course, I'm going to say you cannot do this without a dietitian, but I honestly think this is the one presentation of food allergy where you are going to need your dietitian. Timely introduction of food is required. Nutritional status should be monitored. Feeding dysfunction is a huge issue. It should be assessed and managed. And some children with FBIs can tolerate baked food, but bring them in, challenge them, and open up their diets. And so practical pointers for physicians is measure the height and weight, not just weight, height and weight, and plot it on the growth chart. Timely referral to a dietitian, timely referral to feeding therapy, and consider iron studies and vitamin D studies, particularly if there's multi-food avoidance and some picky eating involved. And this is a book, My Dream. I've recently edited a book alongside Marion Crouch, John James, Scott Sicherer. I've written a number of chapters in the book. I edited every single chapter in that book. Every chapter is written by a combination of an allergist or gastroenterologist plus dietitian. It's got fantastic information. You can get it on Amazon. And when I come to South Africa next week, I am going to bring a few signed copies. And so I'm very much looking forward to visit home because South Africa will always be my home. So thank you for listening to me. And I think we have about 11 minutes for questions and answers if there are any.
Wow, thank you so much. That was awesome, Carina. So many pearls and practical pointers, and yeah, it's something that you don't easily get out of the papers. Maybe your book will help us to get through those.
That FBIS chapter is great. I edited, I think we did about 5 versions of that chapter. And so it's got all these practical tips in as well.
Wonderful. So while we wait for questions, I think what I want to say is I agree with you. dietitians are the key to food allergies, and I've got to mention them because they're online, but we've got amazing dietitians at Rima Musa who really are invaluable and basically run the allergy clinic. I think nobody can really do this on their own. And in addition to that, there seems to be quite a different approach often between gastroenterology and allergy specialists when it comes to food allergies. And I see a few of the allergy specialists as well, so they're welcome to comment. So I think for me, the key is that you all need to get your hands into this. And we are definitely seeing this in all socioeconomic groups in South Africa. And I think they're being missed. And yeah, thank you for your talk. I think it will go a long way to addressing some of this.
So what I would like to add is, so I offer a course with Marion Grouch. It's a 10-month course. Many of the dietitians on here did the course. It's hugely expensive in dollars. I wish we don't get all the money, but we do have scholarships. So, and we particularly look for people from, countries outside of the US to offer these scholarships. So if you want to email me with a name, then I can definitely put you in contact with FAIR, who's organizing this course. If you have a dietitian, but one who may not have the skills, then we can train them.
Wonderful. I think you're going to be taken up on that offer. I see a question for you, Carina, who's asking, firstly, thanking you for a very informative presentation, and is asking about the challenge, the FPAS food challenge, and what the correct dose is. And I think my understanding is that it would depend on the food, isn't it?
Yes, but that's a good question. We do actually use that dose range, 0.06 to 0.6 gram per kilo for every food. But it doesn't really work for the very low protein foods because you're going to have to feed the kid almost a bowl of rice to get that amount of rice protein in. Whereas if you feed a child milk, it's very small amounts. I can actually quickly look at my FBI's challenge protocols because I spent my life. Dr. Fleischer, who's not on this call today, he writes his challenge protocols on a Sunday night. So on a Sunday night, I get text after text to say, how much egg do I give this child of 11 kilos with FBI's, and chicken, that kind of thing. So we do that. We do divide it into 3, but I have to tell you, I think the issue is divided into 3 equal portions because for some children, we are just nervous that they're going to react. So we may actually divide it into 3 equal portions, but then take the first portion and cut it in half. We may even quarter that first portion. Sometimes if they are sensitized to the food, so when we're dealing with atypical FBIs, then we will actually use the challenges that we use for IgE-mediated food allergies, where we have about 8 to 10 dosages. And we know that, they're likely to react, but we start with very, very small amounts. So I think it's sort of like, you can do the 3 doses as the guidelines recommend, and if you do look on PubMed, there's now a number of different challenge protocols published for FBIs because the Europeans are now challenging this American approach, saying perhaps that is not the best way to do that. So anyway, I just wanted to say, but the dose you're stating there and the 3 dosages is really what the guidelines are still recommending.
Thank you. Thanks, Carina. I think my personal view, it's quite a setup to do these challenges, and certainly in the public sector, it's not something we have the resources to do often and for every single food. So I was quite interested in looking at your slides and how you would do challenges for quite a few of the children, and I presume on multiple occasions. So I think that's a challenge for us. There's another question from Christy Victor, who has got a few questions actually, and he's asking about do you recommend eliminating all foods that are normally indicated on a serology pediatric allergy screen? I think you can tell us about that. And the other questions, I think, are more to do with the practicalities of the talk and everything. So we can get to that after the
Okay.
talk.
Sorry, let me just get to that FPI challenge. Our top dose, we actually do 0.06, but our top dose is to 0.3 protein per kilogram. So we do slightly less. And just to give you an idea of these FPI's dosages, if you give the top dose of egg, you give 3 times 7 grams of egg. Now, that is 21 grams, and an egg weighs about 50 grams. So over the course of the morning, you're going to give less than half an egg. But if you go for that lower dose, the 0.06, you're going to give 1.5 gram of egg 3 times. And so 1.5 gram is not, it's almost like quarter of a teaspoon of egg, 3 dosages. So you can see it can get very low. But if we are very worried, we may even divide that. But with rice, you have to give that much with rice, we give a quarter of a cup and we divide it into 3, just to give you an idea, because that doesn't work. Okay, so Christy, okay, so first of all, that number 1, there's allergists in America that makes a life out of answering that question on social media. So first of all, we shouldn't do those pediatric screens. They are terrible. And secondly, absolutely not. Those foods that they are sensitized to, they should actually eat. Okay, because if you can get a child that's sensitized to eat a food, you're highly likely to prevent food allergy. But if you don't get them to eat the foods they're sensitized to, I can almost guarantee 100% that they will develop an allergy. So it's a terrible thing to screen a kid and tell them not to eat foods because they're sensitized. But here's now the dilemma. Now you've done it and you have these positive tests, and you're worried to introduce a food at home because they may have symptoms, and you haven't got food challenge facilities. Okay, so that's why we shouldn't do the screening. Because if you don't know a child is sensitized to a food, they can just eat it. But once you've done the screen, you're in a dilemma. And you're going to have, if you can't convince the parents to do it at home, you're going to have to find somebody that can challenge that kid, because you do not want a child with 10 food allergies at the age of 2 because you did a screen, which you shouldn't have done when the child was a baby. So that's all I can say about that. I don't know about your CPD points, but I hope so.
Unfortunately not for this talk.
Okay.
But if you come to Johannesburg on the 18th, we will give you CPD points.
So somebody wants to know if, we accept, scholars from Africa. I would love to. I would absolutely love to, but we haven't got any scholarship in place. But I'm working with some very, very rich people. He owns a car manufacturer company. I'm not going to say his name. And I'm trying to get scholarships in Colorado for people from Africa. And I promise I'll email Dr. Tim de Meyer if I find anything to let you know. Okay. So, and then my email, I'll put it in the chat for you. I don't mind. You can email me. I'm one of those crazy people that answer my email. I never go to bed unless my emails are on 0. So I will answer you, colorado.org. There we go. Okay.
Thanks, Carina. That's amazing. I certainly can't keep up with mine. Any other questions from the audience? You're welcome to type or to raise your hand. Don't see any at the moment, and I think we are close to the end of our time slot. So last chance, if nobody wants to, then I'm going to say a very, very big thank you to Carina. We really enjoyed having you on our and I think everyone from your talk, as I said, it's quite rare that you get such practical advice so nicely. So thank you so much. I also want to thank Echo New Mexico India team who do the technical side of things. We do record these conversations, and they'll be available on the Gastro Foundation website. Thank you to Cheryl and to Karen, who always run these like clockwork. And also thank you to our Rahima Musa allergy team and the dietitians for putting us in touch with Carina and really enabling us to have such an excellent talk. Thank you. So last one, thanks for the sponsors for the Gastro Foundation. And next week, we will be talking about hepatocellular carcinoma at the same time in the same place. Thank you very much, everyone. See you
Thank
soon.
you for having me. Have a good day,
Thanks,
everyone.
Carina.
Bye.
Bye.